Okay, we'll go ahead and get started. This is the Respiratory Therapy Department meeting for February 2025. We have quite a big agenda, so I will get to it. We'll start off with a brief reflection. This is a quote from former President Barack Obama. Uh, if you're walking down the right path and you're willing to keep walking, eventually you'll make progress. So I thought that was pretty fitting for our Woodland Hospital and for each of us individually. Good evening, or good afternoon, rather, Emily. Thanks for joining. Okay, so
Hello.
hi. So our agenda, we actually have quite a bit to go over today. A lot of hanging topics that we go over month to month, top to bottom. Accounting, productivity, some current events, RT equipment, team, employee satisfaction, education, unit-based practice council. Carrie and Danielle are obviously not on the call, but there is a pretty significant update that I'll touch on when we get there. Scanning scores, positions, which actually slide was removed because all of our positions have been filled as of Taylor Hodge. So we are at full staffing. Kudos, which we'll announce at tonight's department meeting, and then open forum and questions. All right, so accounting, year-to-date productivity, we're actually crushing it. A lot of these gains have been realized, as you probably know, for over the course of the last 4 to 6 weeks, where we have been particularly busy, not just in the amount of patients that we've had in-house, but in the respiratory-specific patients that we have, whether it's breathing treatments or ventilators, BiPAPs, what have you. We've been working very hard. We've been seeing a lot of patients and doing a lot of good work. So, what's good about this is we are very healthy moving into the final quarters of the fiscal year, which means that we will be able to easily offset the trainings for not just Taylor, but some of the other RTs in the department, which are taking on some additional responsibilities in our EEG program. So this productivity will help offset the cost of training those individuals. Year to date overtime, still very favorable. We're at 1.37%. Just again, for your information, the target for the organization and every department is to have a year-to-date overtime percentage of less than 2%. So we're right on target. That's not because we don't want to give overtime per se, but mostly it's to make sure that we have the adequate staffing day in, day out. So, staff members don't feel burnt out or don't get burnt out. So overall, the numbers are looking great. Productivity, again, this is something that we've gone over since the beginning of this fiscal year, when there was quite a significant change in the labor standard, the adjustment that is made with our RVUs. And then just to kind of shine some light on how those numbers or where those numbers come from. Every activity that we do has, or mostly every activity that we do has an RVU that's associated with it. Most of everyone in the department is very familiar with that at this point, with the emphasis that has been placed on it, plus the handouts and what's posted in the department. But roughly, it's 30 RVUs, 30 procedures that we actually get compensated for our time, and roughly 30 of them will make up or offset the cost for one full-time employee. And as you can see from the previous slide, basically those numbers get into our productivity. So we're overproductive. So we're doing phenomenal. We're doing great. And again, we're in a really good position as we head to the end of this fiscal year. Current events. So I sent this out in Tiger yesterday. One of our sister facilities reached out. The manager of respiratory therapy at Mercy San Juan. They're actually going to be hosting a in-service event, a luncheon at their facility. No CEUs will be provided, but they will provide lunch. This is entirely voluntary. I think everybody knows that our pulmonologist does not prefer this mode of ventilation, but if you're interested in just for your own knowledge, getting some additional training, at least lunch will be provided. So if you're able to make it, if you're interested, this is the information. They do ask that you RSVP so they can get an appropriate head count before the in-service happens. And that QR code for RSVPing is at the bottom of this announcement. Okay, again, this is just reiterating some things that I've already put out on Tiger Connect. So e-cylinders on BHU. Um, we do have two e-cylinders now that are basically establishing a par level in their stockroom. They don't have the space nor the crate or the regulatory flexibility to have additional e-cylinders placed on that unit. So what the ask is that only two be kept in dollies on the unit, and as they are emptied, to be brought over into either 3A or 2A, and then switched out with a full tank. This is something that has been communicated to the nursing staff as well. I have the support of the behavioral health nursing director that her staff will also be assisting us in managing these e-cylinders in BHU. And then additionally, more often than not, what happens is there are HHNs or medications in BHU. Doesn't happen all the time, but sometimes our patients up there also receive breathing treatments. And as a means to ensure some more kind of safety, to avoid any kind of device or devices that could pose as a potential ligature risk, we have instituted, which apparently has been on the books previously but fallen off, is automatic therapeutic interchange from HHNs in BHU to MDIs. This will make it so you don't have to cart around an additional e-cylinder for breathing treatments if or for oxygen if you're using wall oxygen to render a treatment and the patient's already getting a nasal cannula. You can administer the medication, bring it back to the med room, and then move on. This hopefully will ensure safety and reduce the amount of equipment that we have to use up in that unit. And then MDIs in the ED. So, as you guys probably know, there are instances where some providers will order a MDI and treat in the ED. While this is a valid order, what we are mandated to do, because ED patients are considered outpatients, we have to dispose of the unused MDI. There can be anywhere from 30 to 60 puffs in any particular MDI unit. So it's incredibly wasteful if we use MDIs in the ED because we just have to destroy them afterwards. So in collaboration with our CMO and with the director of pharmacy, we are going for moving forward with an automatic therapeutic interchange for all MDIs for the ED patients to HHNs. This doesn't, however, mean that providers can't order education with spacers, but we're going to be utilizing spacers alone at this point for any kind of training that the provider would be interested in giving their patients. Okay, so this is again a hanging slide from last month. My security manager, Brian, and I are still working on the parking policy and adherence to. There's a pathway module that is an attestation, an acknowledgement of what our current parking policy is. Everybody on campus, all employees have been sent a form, a Google form, to supply their information about their cars and their leaders and their name, their employee ID, whatnot, in order to be issued a parking permit. Brian and I are in the just in the thick of it, going through and handing out parking permits to employees that have completed those forms. If you haven't completed the form, please do so. If you don't have access to the form or have lost it in your email, let me know. I can send it to you. The intent with this is beginning of April, after the attestation through pathways has elapsed. There will be strict parking enforcement conducted by our security team. So just as an FYI, if you haven't done it already, please do so soon. RT equipment, just a general hanging slide. As of late, and really more often than not, you guys do a phenomenal job of breaking down equipment, cleaning, dressing, bagging, tagging. Do remember to continue to do that moving forward. Obviously, we are in the TJC window for inspection, so always important, but extremely so now. Okay, so this is a little bit of a new update. This has just happened a couple of days ago. There's a new PAPR process. All PAPRs on the floors have been collected and brought down to the basement, the old pharmacy, the new transport and EVS space. It's a staging area where we can ensure that we have clean equipment, not only clean equipment, but equipment that has been appropriately processed and has fresh filters and charged batteries. What has happened since COVID is that our biomed team has actually stepped away from managing these, and therefore there has been absolutely no maintenance done, no PMs done, no filter changes done, or just general inspections done since then. Now, as a means to help streamline this process and ensure that we have good, safe equipment for our staff, we have again collected all these peppers and staged them down in the basement. Should you need a PAPR for your shift, the process essentially will be to enter that information into teletracking. Transport will bring it up to the ward or unit for the individual. Then when you no longer need it, the PAPR hose needs to be placed in a red bin to go down to sterile processing, because per its instruction for use, it has a special clean that needs to happen before it can be reused. Then place all equipment, battery, charger, PAPR, belt, blower motor materials back into the tackle box, the black tackle box that it was sent up in, and then teletrack it back down to the basement. So far, this has begun as of effective a couple days ago on the 21st, and it has worked fine. We have an overwhelming amount of PAPRs available should we need them. But this just helps kind of get a stable handle on our inventory and ensures that we have eyes looking on them, making sure that the filters are clean, and more importantly, the devices are clean and ready to use. Okay, so something you guys may or may not be aware of in the RT circles is that Hollister has announced a massive recall of their ETAD, certain models of their ETAD endotracheal tube holders. This is not just affecting Dignity Health. This is a nationwide recall, which initially did not affect us. It didn't affect our specific lot number. But what it is doing at this point, it is affecting our ability to order new product. So just this will be put out in our huddle on our huddle board in the coming days and weeks. Working with materials management, we found a substitute from Hollister that we are going to attempt to order, and that is what we have on the screen right now. Functionally, it looks pretty similar to what we are familiar with. We're hopeful to receive this in stock effective either today or tomorrow. Beyond that, I've worked with Clyde and Materials to up our par level for our soft Dale ET tube holders. And then outside of that, working for some solutions of old school taping of the endotracheal tubes. Obviously, the intent and the idea is to avoid tape because it makes the workflow extremely difficult, especially when we have to retape every couple hours to move the tube position. But unfortunately, that might be an eventuality that we have to face. But as it stands right now, it looks like we have a comparable substitute that we are going to be able to move forward with. And as details come out, I'll obviously push that out to the staff. EKG stickers. So this is something that came out from one of our mock surveys regarding the pouches that our EKG leads come in. These are the little adhesive leads when we do a 12 lead anywhere in the house. They should be contained within a pouch that has a Ziploc ability. But what was found is that per the manufacturer, these stickers go expired after 30 days of being opened. So I'm currently working with infection prevention and Sherry Allswang from ED to land on a pre-printed sticker that we will be affixing to these pouches just to indicate either when it was opened or when it expires, just as a reference to the staff member when they need to open up a new pouch. Um, more, looks like Emily got booted off. She's coming back in. More to come as soon as we land on the sticker, standardized sticker for the whole house, and it'll be the expectation of both nursing and RT to date and label these pouches as they're opened. Hand hygiene, again, very important all the time, but extremely important as we are being in the window of our TJC audit. And more than that, there are leaders everywhere within the facility that are constantly watching to make sure that we are doing appropriate hand hygiene. So, um, generally, RT comes back doing exceptionally well, doing appropriate hand hygiene, depending on the isolation type for the patient. So continue the good work. And actually, before we go on, one other just, I don't have a slide for it prepared today, but just for your general information, we're going to be making a little bit of a change in the way in which we capture end tidal CO2, particularly with our patients that are on G5 Hamilton vents. The standard practice previously has been to use a Luralock side stream adapter and hook that directly to the nurse's monitor at the head of the bed. Um, our G5s actually have the capability of having a hardwired entitled CO2 that goes to the vent directly, as opposed to having to cross over the patient at the head of the bed to the nursing monitor. I've already spoke to Dr. Robinson and to Celeste, the new ICU manager, or the returning rather ICU manager of this change in process, and they are all on board. What it will do for our G5s is streamline where we can find the information that is pertinent to what we need to chart in the iView every 4 hours. We'll have end tidal CO2 readout on the ventilator itself, as well as all the other pertinent information, of course, excluding the SpO2 heart rate, which we'll have to get from the nursing monitor. This is more of a standardization with the rest of our sister facilities as well as a safety upgrade. So we have less cords that are crisscrossing up at the head of the bed. Those have been ordered effective day before yesterday. So we should be receiving those, and there will be a brief in-service to follow once they land here. It's extremely straightforward. It's just it's another piece that goes in line with our current vent circuitry. All right, so just hanging a slide here. Again, the accuracy of your time card is your responsibility. Do remember to sign off on this at the end of the pay period to ensure that everything is appropriate and up to date. Generally, this has been not an issue in the department, but just keep up the good work. Okay, employee satisfaction, my voice survey. So last month there was a brief departure from our mid-year My Voice survey results, I took a question from the Pulse survey that was administered late last year, November, December. We're actually going back to the mid-year My Voice survey results just simply because there were too few respondents on the Pulse survey. So with that said, I will broach the you guys with this question to kind of solicit some maybe some feedback, maybe some understanding, should you guys have any kind of uh, suggestions you might have to make this any better. So again, overall, the scores that I receive on the employee satisfaction survey are not across the board particularly low. I mean, generally, there are all very high marks. So what I try to do is find of those, the ones that score on the lower end. And this happened to be one of the questions that's what that scored on the relative lower end of the spectrum. And the question is, if you can't read it, this organization provides the same quality of care to all patients. In other words, we are equitable in the care that we give to all patient types that we receive. So I wonder for those of you that are on the call, if this is something that represents your idea, or if you can think of a way in which this can be improved, or the perception of it can be improved, or just generally any thoughts about this at all.
I honestly don't know why that score low. I don't think we give different care patients. I mean, maybe we have patients that are super frustrating, and but I don't see how that would affect our care of them. So I'm not sure why that was score low.
Yeah, thank you very much, Emily. It's really hard to say. I know that yeah, from the standpoint of respiratory therapy, at the very least, and at least in my observations of other departments, um, it certainly seems, from my vantage point, removed as it may be, that regardless of the patient disposition, the quality care is standardized. The amount of compassion that we render towards those patients are the same. So, yeah, I'm not sure how to move that needle, or or what might be the impetus for this particular question scoring the way it did. Um, Anybody else on the call have any ideas or some comments that they would care to share? It's okay if you don't. Okay. Yeah, something to think about. Like I said, just to close out, I think from at least my vantage point, we're very equitable in the care that we give to everybody that comes through our doors, especially here at Woodland. Okay, another hanging slide. This is education, just a brief touch point on the various resources you have available to you to offset the costs of additional education, whether that is brick and mortar, getting a degree, getting a certification, going to a conference. Both EdAssist and the Education Fund are there for you to help offset those costs. And if you need it, ACLS, PALS, BLS, these are some dates and times. All of this information is in your email provided to you by our education department here at Woodland. Um, so just an update. Okay, Unit-Based Practice Council, like I said, neither Karen nor Danielle are on the call, but we have quite a big update that I'll be working with them closely on, and the department, more broadly, the department at large. And that is where I'm going to be moving forward with deploying, crafting, and authoring an RT evaluation and treat protocol here for Woodland. Um, this is no small feat. A lot of our sister facilities have this already well established. Um, I worked very closely in development of an RT evaluation and treat protocol at my former facility. And I think it is time for us to go down this road. Obviously, this takes a lot of buy-in. There's a lot of stakeholders that have a big interest, keen interest on what this ultimately will look like, what kind of autonomy it will allow for, and what it is that we'll be able to help do. And I've already started those conversations with our pulmonologist. He's actually very interested. Him and I are going over a sample policy as we speak. Next steps for me will be to basically check the temperature with our chief medical officer, the director of med staff, because ultimately Dr. Robinson is going to be, ordering and conducting the treatment more or less of his patients. Where I envision our RT evaluation and treat protocol really to be effective, and the population I see us helping the most are those that patients that are either E-dipped or on the floor, or really any patient that is the primary care is being done or overseen by one of our hospitalists. This will allow us to intervene acutely faster. We obviously reach out to our doctors and have a good working relationship with them currently to get the orders that we need. But this way here, we might be able to offload some of the responsibility of those docs by directly intervening with patients acutely that are going through some process. So just wanted to let you guys know collectively that this is being worked on, and um, I look forward to collaborating not just with the Unit-Based Practice Council, my colleagues in leadership, but also all of you. Um, a lot of it will be arterial blood gases, involving arterial blood gas ordering, treatment modality ordering, treatment ordering, and and so forth. So very exciting stuff. Look forward to working on this. This is a good project. It's a very good thing. Okay, scanning scores. Again, another touch point. Just be sure to make sure that you're scanning every medication every time, as well as patient barcodes. Want to make sure the right patient gets the right med at the right time. This is something that I audit daily. And for those that need to that have some challenges. I speak with them directly. More often than not, the challenges are having to do with our equipment. So again, I would encourage, if you come across a broken wow scanner, whatever, please take the time to put in a ticket, get a different computer scanner, get a different wow, and do the right thing. It's a safe thing to do, and it's a national patient safety goal as well. And kudos, like I said, kudos will be acknowledged tonight, the night shift meeting. And that is seemed like a whirlwind. That was quite a lot, but that we are at the end. So I'll open the forum to any questions or comments that you may have. Going once, going twice. Oh, yes, of course, Ina. I know you've asked about that before, and it's time. So you're very welcome, and more to come. Okay. Again, thank you all very much for your attendance, and I will all see you all very soon. Have a good
Thank you,
afternoon.
Brian.
Thank you very much. Bye.
Bye.